Today we'll be talking about the Richmond Agitation Sedation Scale, otherwise known as the RASS. So what does this measure? From the ICF model, the impairment section, it will measure arousal. There's a 3-item test with a 10-point scale that will assign a number to the patient's current level of arousal. So the positive numbers will correlate to a state of anxiety or agitation, 0 will correlate to a normal calm and alert level, and the negative numbers will be associated with sedation. The highest score is labeled as combative and the lowest scores are rated as unarousable. It's a pretty quick test made to be administered in 60 seconds or less, and it was actually created to be used on the acute or inpatient population. A few specific examples are people who are medically ventilated, anyone who might be in the hospital, critically ill individuals, people receiving sedative medications, and people who have a fluctuating level of consciousness and arousal. Here is the test. On the left you can see the positive scores, which correlate to the agitated states, 0 which correlates to alert and calm, and the negative numbers which correlate to a state of sedation. On the right there is a description for the criteria needed to be labeled that score. So the 3 items are as follows. First, you need to assess for a 0, which is alert and calm. If that doesn't work, or if that's a no, you need to next go toward the positive numbers to the agitated states. Again, you can see the criteria under description. So this person might have, they might be showing anxiety or apprehension when you approach them. They might have non-purposeful movements, or they might be pulling on their wires or their lines and things like that, or they might actually pose a threat to you or anyone else in the room. If that is no, you need to move to the negative numbers towards sedation. So there's more specific criteria that you can read by yourself under these numbers, but you're going to be looking for a decreased response to your attempts to wake them or get their attention. So maybe they don't make eye contact with you, or you can't wake them up unless you raise your voice or make contact with them, maybe a sternal rub or something, with the lowest score being not able to arouse the patient. So let's take a look at what a 0, alert and calm, would look like.
Hi, Maddie. How are you doing today?
Good, how are you?
I'll be your doctor.
Oh,
Next, let's look at a -5 or unarousable.
Hey, Maddie. Are you ready for therapy today? Maddie, can you move your arm for me?
Finally, we'll look at a +4 or combative state.
Hi, Maddie. I'm Sam. Okay. Oh, hold on. Stop. Nurse!
So the psychometrics of this test are really good. There's an excellent inter-rater reliability, over 95%. And as far as validity goes, this study looked at 3 different scales used to measure arousal, with a high correlation to 1 and good correlation to 2 others. Some advantages that we noticed: it's very generalized. It can be used by any medical professional, not just PTs, and also it's been shown to be good when administered in English and Portuguese. It's easy to use. It can be administered in a minute or less, like you saw in the videos, and because of how simple the scale is, it might actually be memorized pretty easily. Specific to cardiopulmonary populations, we know that they might be sedated because of surgeries, ventilators, drugs for pain management, anything like that. But they might also be agitated because of ICU delirium, adverse reactions to their drugs, and just the ICU not being the most comfortable place to be. As far as acute care goes, we wouldn't actually make any modifications because, again, the study was created and targeted toward this population. Another advantage we saw is that the scale or the test will measure both aroused states or agitated states, and sedated states in the same scale. So it can cover both ends of the spectrum. Also, it's freely accessible online, so that limits accessibility as an issue. Moving on to the limitations, we found that people with auditory or visual impairments may have trouble responding to this test because, as you saw in the video, you use auditory and visual cues to try and arouse them or get their attention. Also, outside of English and Portuguese, this test hasn't had much validity testing done in other languages or parts of the world. Our clinical bottom line is that this is a great test to use for your acute populations because of its generalized application, the ease of use being administered in 60 seconds or less, and how easy it can identify whether or not a patient is ready for therapy that day. If you score them as 0, they're likely ready to participate with you in the therapy, but if they're on the extreme ends of the spectrum, they might not be appropriate for a PT that day, and it can be easily communicated to other professionals what kind of state they're in. And these are our references. Thank you.